Hello, this is Podmedics. Welcome, and this is going to be a podcast on hypocalcaemia, low levels of calcium in the blood. So we're going to cover some basic science and a very mini case about a patient that I saw with a low calcium. I'm just talking about things that you would do, what goes through your mind in such a situation. We're going to start with a few questions to jog your memory. Question 1. Can you name some organs or electrolytes that are involved in calcium regulation? So here I'm thinking of things like parathyroid glands, the kidneys, the liver, bones, and the electrolytes and vitamins would be vitamin D, and then phosphate and magnesium. So there are a lot of different organs and different electrolytes and different things that are involved in calcium homeostasis. And problems with any one of these can cause a low level of calcium. Okay, question 2. So we figured that we need this vitamin D for calcium levels to be adequate. So this question is, where does vitamin D come from? And is it soluble? What sort of chemical, what sort of compound is it? I hope that was enough time. Vitamin D is a steroid hormone, and it's one of the fat-soluble, one of the DEEK hormones. And it comes from the food, things like oily fish and eggs, but it also comes from the sun. And when UVB, particular wavelengths of this UVB light, react with the cholesterol derivative that's in the skin, and you can produce vitamin D. And the vitamin D that you have in your body, you've got D2 and D3, but we just call them calciferol really, but they've both got different names, and different plants and animals make different vitamin D. I don't think it makes much of a difference really which one the humans get, whether you take in vitamin D2 or D3, but they're researching it at the moment. Okay, so third question, we've got this vitamin D in our bodies. How do we activate it, and what do we call active vitamin D? Well, as we said, vitamin D is usually this biologically inert substance, and your body has to activate it through a load of reactions. And these are hydroxylation reactions. We start with one in the liver, and then we get in the kidney, and we end up with having three. We end up with the compound calcitriol, so 3 OL groups. And pharmacologically, we give people the preparation called alpha-calcidol. A for active. Alpha-calcidol is vitamin D that has already been activated, so it's already had these hydroxylation reactions. So you give it to people with kidney or liver disease, and that means they get adequate vitamin D. Whereas if you'd just given them regular D2 or D3, then they wouldn't be able to activate it. It would just stay inert. It wouldn't really help them. Okay, question 4. We're nearly done. Why do we need vitamin D, active vitamin D even, to absorb calcium? What's the link between vitamin D and calcium absorption? Well, vitamin D increases the level of calcium in your blood because it increases the amount of calcium that you can absorb from the gut, and it also increases the amount of calcium that's resorbed from the kidneys. So if your calcium is okay, then you don't really need to take any more from the bones. So vitamin D helps you pick up and hold on to your calcium. It stops your kidney getting rid of so much, and it allows you to take up more from the gut. So it's like a bodyguard of the calcium. It's helping you keep it, and it's stopping you losing it. What about bone disease? Question 5. What bone diseases do you get from low vitamin D? This is an easy one. Well, you need vitamin D for mineralization. So if you don't have vitamin D, you end up with rickets in childhood, and adults get osteomalacia. And final question, what's going on with these parathyroids? How are they involved with calcium homeostasis? Well, parathyroids obviously release parathyroid hormone, and this is released when ionized calcium levels in the blood are low. and they raise calcium and they lower phosphate. They don't affect uptake, whereas vitamin C affects uptake and works on the kidneys as well. Parathyroids don't affect the uptake in the gut, but they work primarily on the kidneys by stimulating 1-alpha hydroxylase, which is the hormone that does one of the hydroxylation reactions to make vitamin D active. So we're going to get more calcitriol when we activate these parathyroids. So we get more calcium resorbed and more phosphate released. So they're the 6 questions. So we've covered quite a lot there. We've talked about what vitamin D is involved with, and parathyroids involved with, and how we uptake calcium and where it all comes from. So there are a lot of things going on, and any problem with one of these processes can lead to a low calcium level. We sort of touched on the fact that you've got normal vitamin D and it has to be activated in the liver and then the kidneys, and that the renal 1-alpha hydroxylase is stimulated by parathyroid hormone or by a low phosphate. Just the last thing to say is that vitamin D doesn't just float around by itself in the body. It gets bound to a carrier protein, which has the most imaginative name. It's called vitamin D binding protein. So it transports it around, and this binds to receptors, also imaginally named as vitamin D receptors, and these receptors are in the nuclei because, as I said, it's a steroid hormone. So it gets into the cell, it can go through the membrane, get to the nuclei, and then it acts as a transcription factor. So we get increased gene expression, so we get more transport proteins, and that's how we can absorb more calcium from the intestine. So it's all quite complex. We've got genes, vitamin D, leading to up-regulation of the genes that are required to make these proteins so that we can transport calcium from the gut. Okay, so we've dealt with all that stuff. We get vitamin D from the sun and food, it's activated in the body, it works as a transcription factor, we make more proteins, we absorb more calcium from the gut. We release parathyroid hormone when calcium is low, and it helps to increase uptake of calcium by increased hydroxylation in the kidneys of inactive vitamin D. Okay, so that is all the basic physiology. You might want to listen to it again. I went through it quite speedily, but let's put this into practice now. Here's the case study. We're going to discuss how you interpret a calcium result from a lab, practical actions, and things to take into account. Okay, so it is your first day on call as a doctor and you don't know anything. And you get bleeped by the nurses and they call you up and they go, the lab has just phoned us. What are you going to do, doctor? Mr. Smith's calcium is low. So you're thinking, oh gosh, I don't remember any of my calcium and physiology. But you look it up on the computer because you've got to do something. And you see there are 2 figures there. We have a value for calcium and we have a value for corrected calcium. Now what's all this about? Well, which one is correct? Which one are you going to pay the most attention to? That's actually, the correct one is the corrected one, because a calcium level measures total calcium, but the bit that's active, the bit that's working, is the unbound and ionized 2+ calcium. And the reason for this is that most calcium is bound to albumin. 40% of it is albumin bound. So regarding your levels of albumin makes a difference in how much of that total calcium that the lab has measured is actually free and activated. If you're malnourished and you've got a low albumin, there's less calcium being held onto, so a bigger proportion of the total calcium is active. And if you have the opposite, if you have a high albumin, then there'll be less of the total calcium that is active. Usually your lab will work this out, so you don't have to remember the formula, but we'll put it in the slide so that you can read it. So your baseline albumin is about 40 grams per litre, and if this is low, more of the calcium will be free. So for each 4 grams of albumin that you have less than 40, so we had 36, we'd add on 0.1 millimoles per litre. So as albumin drops, for each 4 gram you add on 0.1 millimole, because your calcium will be higher. And the opposite works if you've got a high albumin. You'll have less free calcium and less active calcium. So for each 4 grams of albumin above 40, you subtract 0.1 millimoles, because your active calcium will be lower. Okay, so while we're on this topic, what about the parathyroid hormone? Well, if plasma ionized calcium is low, parathyroid tries to increase this calcium. So we get more parathyroid, and we got some sort of seesaw effect that as the calcium will go up, the phosphate will go down. And we've already talked about the fact that it works on the bones and the kidneys. Okay, so fledgling junior doctor, what are you going to do? Well, obviously there's a low calcium and then there's a low calcium. How low is this calcium? And you're also going to examine the patient for some clinical signs. Now, a normal calcium is in the range of about 2.2 to 2.67 millimoles per litre. And obviously, different laboratories are going to vary. So you probably don't need to bother learning this, you just look at the reference range. In this case, let's say Mr. Smith had a calcium of about 2. So he's clearly low, but it's not awfully low. So let's go and talk to Mr. Smith. Is he showing any symptoms? And what are these symptoms we're expecting? And we get there, and Mr. Smith is sitting up in bed reading the latest Dan Brown novel, and he seems very unconcerned by your worry. And in fact, he gets a bit annoyed because you start poking him in the face. You stick a blood pressure cuff around his arm, and you start hitting him with the tendon hammer and asking him what he thinks are silly questions about whether he's got numbness around his mouth. So what are these things I've just described? Well, I've described perioral paresthesia, numbness around the mouth. Funnily enough, when patients are very anxious and hyperventilating, they get the same sort of thing, because when you hyperventilate, you get a respiratory alkalosis, and this means that more of the plasma calcium binds so that less of it is ionized. So you get this sort of an effective hypocalcaemia. But really you've got a normal calcium, but just when you've got a respiratory alkalosis, it looks like your calcium is less because less of it is ionized, because more of it's been bound. The tapping over the facial nerve, the hitting him in the face, in front of the ear, sort of where the parotid is, that's called Hofsteg sign, Chvostek. And this is when you just tap it and you get people's faces twitching. But about 10% of normal people have this as well, so you can try it on your friends. The blood pressure cuff is Trousseau's sign. And when you get the blood pressure above systolic, you get ischemia, and this causes carpal spasm. It's carpopedal spasm. So you get an opposed thumb, flexion at the MCP joints of the hand, and extension of the interphalangeal joints. So it's this particular hand position that you get. So basically all that's happening is that you've got low calcium and all the nerves are just super excited. So everything's a bit excitable, reflexes are up, you tap on things and you get them twitching and moving and things going. So, as I've said, Mr. Smith isn't symptomatic and he's just a bit irked that you've come and started prodding him and poking him and asking him questions. So what would we do if he was symptomatic? And what would we do if his calcium was really low? Well, if he was symptomatic, we would be acting now, or if his calcium was very low, we'd be doing something immediately. But slowly, because you can get arrhythmias if you start correcting electrolytes too quickly. And what you do is you give 10% calcium, specifically calcium gluconate, and you give 10% of 10 to 20 mils, and you give it slowly in 50 to 100 mils of 5% dextrose over 5 minutes. Okay, so 10% of 10 to 20 mils of calcium gluconate in sugar in 50 to 100 mils of 5% dextrose. You can give calcium chloride instead, which has got more calcium in it, but that's a bit irritant to the veins. And you would use an ECG to monitor someone. And you're going to keep monitoring them, seeing if their calcium goes up. And if it's not sustaining the calcium, then you might have to put them on a slow infusion. And you can repeat this as required. Other things that might need correcting are the magnesium and the phosphate level. If someone's got very high phosphate, you may need to give them phosphate binders. And you don't want to correct things too quickly, because if you correct too much calcium, you can get deposits of calcium stuck around the body. So I've said that you're going to act if you have a really low calcium. But what is a really low calcium? Well, probably a calcium less than 1.75, because less than this you can get laryngospasm. If it gets less than 1.5, apparently, you get laryngospasm, which is an emergency. So obviously, you want someone to not be able to breathe. So in this case, Mr. Smith, what are we going to do? We're just going to give him a few grams of oral supplements which contain cholecalciferol. We're just going to give him a bit of extra calcium, some tablets, and gradually over the next day or so we're going to correct his calcium, because he's not in any problem. We know that it's low, we're just going to deal with it a slower, easier way. Obviously, Mr. Smith, we're worrying, why has he got a low calcium? Has he got renal disease? Are his creatinine and urea levels raised? What's his parathyroid hormone levels like? He hasn't just had his parathyroids out. What thyroid surgery has he? Has he got antibodies against parathyroid hormone? And also things like anti-epileptic drugs. They reduce your vitamin D levels. Has he got malabsorption? Is he systemically unwell? Has he got pancreatitis? I hope this has given you a bit of an idea about the physiology of calcium, and what causes the low calcium, and how you deal with it, and what the symptoms and signs are. And so that when you're that fledgling junior doctor and you start your first day and you get called to the ward to deal with a low calcium, you're not going to panic, you're going to know exactly what to do. So that's really everything about low calcium.